Okay, so 11 o'clock prompt, as we said. I can see James has joined us there, and your scrubs, you're on mute just at the moment, James. So at our Respiratory Collaborative, we've been trying to secure James Calvert to attend for some time, but he lives in, well, he works currently in Bristol, and he's, I know, very busy clinically. But the advantage of the virtual platform is that he has been able to make it this time. So we're really pleased to have you, James. So we've been doing a lot of work on COPD discharge bundles in Kent, Surrey, Sussex, and James was at the forefront of developing the BTS, British Thoracic Society COPD discharge bundle, and has been involved in some research around that. And he's more recently been appointed as National Asthma Lead. And for this session, it's going to be more about restoring services. I know James is going to cover asthma and also a little bit about COPD and bundles. And he's got a lot of wisdom on these topics, which he's going to share with us today. So as previously, at the end, we'll have time for questions. You can either type them. Surely someone will raise their hand and ask a question in person later on, but we'll see. But we'll give time for that and finish by this session at 11:45. So James, thank you very much and welcome.
So thank you very much, everybody. I've been looking forward to coming to speak with you guys because I have worked with some of you in the past when I was doing the initial care bundles pilot at the BTS, but also I've been incredibly impressed over the years with the work done by the KSS Collaborative. I think you're absolutely class leading in the UK in the way in which networks can work together for patient benefit through improving care pathways. So advance the slide, please. So these are my disclosures. Next slide. Brilliant. So over the next half an hour or so, I'm just going to talk very briefly about the context to the National Asthma Audit, which is one of my hats, and then look at some of the preliminary results that are emerging from the audit. And then I'm also going to signpost you towards another bit of work I've been doing, which is a bit of quality improvement work with NHS commissioners on severe asthma services, what they look like. And then finally, the last little bit will be a little bit of a sort of a critical look at care bundles and some of the lessons learned from work that some of the people who are online now have been involved with. So next slide, please. So Andy has just given a very good overview of why respiratory medicine is still incredibly important in the UK, and more important now than ever before. This is a screenshot from a document that's just been produced by NICE, and it reminds us that 1 in 5 people in the UK have a respiratory condition, and it is the 3rd biggest cause of death for people in the UK. Next slide. And unfortunately, when we benchmark ourselves against other European countries, we do not perform at the level that I and all of you would like, in that respiratory disease accounts for 14.5% of all deaths in the UK, and the EU average is only 8.5%. So the only country with worse respiratory mortality than us is Turkey. And we all know from our own personal experience that there is huge variation in care across the country, and variation is sometimes good if that variation is to meet patients' needs, but also variation can sometimes reflect access to services and care. Next slide. And that indeed is confirmed by the NICE report, which shows that respiratory disease is very much a disease of social deprivation. And this is the distribution of asthma across the UK, but on the right-hand side, but on the left-hand side of the screen, the graph shows that the more deprived the area you live in, the higher the mortality from respiratory causes. And that is certainly something that is remediable to system change overall. Next slide. So I lead the adult asthma component of the National Asthma and COPD Audit, and it's a large program that really is only just beginning to come come to maturity now. The first part of the audit to get up and running was the COPD audit. It's been running since February 2017, and over 270,000 individual cases have been entered. And in terms of process reliability, some of the areas of COPD care that are emphasised in COPD bundles have doubled in terms of the rate in which they're delivered. Adult asthma is much newer. We produced our first report just as COVID went live at the beginning of the year, unfortunately, and we've had 30,000 cases uploaded so far. Pulmonary rehab and children and young people's asthma came online most recently, and something that is absolutely vital to the audit is that we get outcome data and primary care data. That's proved quite challenging because of NHS data governance, but it's been overcome nationally for outcomes and in Wales for access to GP data, so that we'll be able to link patient episodes in hospital with the care they received before and after admission. And then a final piece of the audit is a focus on quality improvement, and over 500 people have attended quality improvement face-to-face sessions we ran prior to COVID, and I'm working with the Royal College of Physicians to get a respiratory specific quality improvement programme set up that can run virtually. Next slide, please. And I think one of the key things about the National Asthma Audit, and one of the things I reflected on listening to Andy talking about the outcomes that are going to be specified for networks, is I think in this day and age, outcomes need to be patient driven. If you're going to measure the success of a service, you need input and advice from patients about what to measure, because I think long gone are the days when we should measure things in the NHS that are easy, and I think we should measure things instead that have value. And we've worked with patients throughout the whole programme, and we've contacted patients both through individual clinicians, but also through Asthma UK, British Lung Foundation, and the other patient-facing charities. That includes children and young people as well. And patients help to structure the original audit. They review all our publications, and they've also specified improvement objectives as well. Next slide, please. These are the patient-specified improvement aims. They would like to ensure that the quality of care and advice received is the same in every general practice, whichever one you go to. When they come into hospital, they would like to make sure they're seen by a respiratory specialist, that the quality of service should be the same 7 days a week. And then finally, the importance of pulmonary rehabilitation was highlighted by patients, and they feel that referral to pulmonary rehab is the outcome goal for COPD they would like us to focus on most. Next slide. So the asthma audit component of NACAP was established as one of the recommendations following the National Confidential Inquiry into asthma deaths, about which I'll say a little bit more in the moment. So Schwab Nasser at Addenbrooke's led a group of people who consulted with patients and consulted widely across the profession to develop the specification for the asthma audit. And we competed in a sort of competition and won the contract from HQIP to deliver the asthma component of the audit. Next progression, please. The audit was piloted widely in the NHS, and finally, next slide. The overall specification was produced and accepted by HQIP. Next slide. So just to remind you of the results of the National Review of Asthma Deaths. So first of all, this was a really in-depth look at the cases of 195 patients who died between February 2012 and January 2013. And I, in fact, submitted one case to the inquiry and was really impressed. So the audit interviewed me for an hour. They also interviewed nurses who cared for the patient on the ward. They interviewed the general practitioner and nurses in the practice, and they interviewed carers. So it was a really thorough look at all aspects of patients' cases to see if there was anything potentially that could have been done to reduce the risk of the individual dying. Next slide. So they identified a number of key things. So first of all, they identified that only a quarter of patients had an asthma action plan. And Asthma UK measures the number of patients with personal action plans every year, and increases slowly, incrementally every year, but nationally, still only half of patients have had the opportunity to sit down with an appropriately trained clinician to discuss their asthma care and have that encompassed in an action plan. And it is an area where there is grade 1 trial evidence showing that it is of benefit to outcomes. Next slide. They found that opportunities had been missed when patients had contact with healthcare. So first of all, 10% of patients died within 1 month of discharge from hospital, and 21% of patients had an ED visit in the previous year. Next slide. A key thing, though, is that the majority of patients were undertreated, either because they were on the wrong medications or the medications they were on they didn't take. So 14% of these people with asthma severe enough that it led to their death were not on an inhaled corticosteroid at all. And as Joe observed, I'm in scrubs, and I've just seen a chap downstairs who has multiple allergies, elevated eosinophil count, and was, in quotes, weaned off his steroids 3 days ago. He took 60 puffs of his Ventolin yesterday because he was having such a bad attack, and came in with a potassium of 3.1 and a lactic acidosis in addition to his asthma. He was just on the wrong drugs because he hadn't had a chance to be educated. The other problem is that 38% of the patients who died had picked up less than 4 of their 12 preventers in the previous 12 months. Next slide. And then finally, the patients, for whatever reason, patients come when you offer them appointments, but 57% of these people with asthma bad enough that they died had never seen a specialist, and 43% had not been seen in primary care the previous 12 months. So lots of challenges for the system as a whole there. Next slide. So the results I'm about to share with you are published in the first report of the National Asthma Audit, which you can look at via the NACAT website. And the second report is complete and is going through the HQIP NHS England approval service. But overall, the data I'm going to show you is based on 30,000 episodes of care uploaded by you and other colleagues across the country. Next slide. So I'm going to focus very much on the priorities, and one of the key priorities in all guidelines is to understand the severity of an asthma attack at the point at which the patient presents in hospital, and then to make objective assessments of severity prior to discharge to ensure that the patient's safe to go home. And peak flow is front and center to that. Next slide. So we found that in those 30,000 patients, 74.6% of patients had their peak flow measured at some point, at least once during the admission, but only 28% had it measured in the first hour and 52% in the first 4 hours. And what that means is that for more than half of patients, they'd been in hospital for 4 hours before an objective assessment of the severity of their asthma was made. Next slide. Overall, 21% of patients identified in the audit as being well enough to do peak flow had no peak flow measurement made at any point during the admission, which means severity wasn't assessed in the guideline recommended way when they arrived, and the safety of their discharge wasn't assessed with peak flow. So one of the key national improvement priorities is that 95% of patients are assessed for asthma severity, including measurement of peak flow within the first hour of arrival in hospital. Next slide. Just to remind you, if you log on to the NACAT website, you can download run charts that show how well your centre's doing for a number of the metrics within the audit, and these run charts update every half an hour. So if you enter new data, you'll get an updated chart very rapidly. And just to remind you, there's benchmarking data here. So the red line on this graph is the UK national average percentage of patients with peak flow measured within an hour. So you can see that's running at about a quarter. And the national average patients peak flow following arrival in hospital at any point is the dotted blue line, and then the solid blue line is actually the performance of my own unit. And you can see that we've been doing a bit of quality improvement work, and we're slowly improving the reliability of care, but we've still got a little bit of a way to go. Next slide, please. The other sort of thing that's emphasised in the guidelines is timely care. And the area where there's best evidence is administration of steroids within the first hour. So this was subject to a Cochrane review about 10 years ago now, and it showed that if patients receive systemic steroids within an hour of arrival in hospital, they're less likely to die and more likely to have a shorter length of stay. And looking at the national data, those who die in hospital generally die between days 3 to 5. So you need to make interventions to prevent deterioration early on in the admission. Next slide. So what we found is that 87.4% of patients receive steroids during their admission, but that still means that 12% of people whose asthma was bad enough that they were actually admitted overnight in hospital, because that's the group in the audit, 12% had no steroids at all. And bear in mind that these are patients where a clinician has looked in the notes and decided that this was an asthma admission. Only 30%, a third of patients, get the steroids within that first hour. And next slide. So consequently, one of the improvement objectives is that 95% of admissions who've not been administered systemic steroids as part of pre-hospital care get those steroids within the first hour of arrival. Next slide. So one of the things we've been trying very hard to do is to use all the possible levers in the NHS to embed good asthma care wherever we can. So one of the groups that I've been working with is the Urgent and Emergency Care work stream at NHS England. And prior to COVID, something that they were looking at to replace in the future measurement of crude 4-hour trolley weights as a performance measure in ED is to look at how the quality of care can be emphasised. And the first hour of care programme is one of the things that they have been looking at. And the things that we felt were important to be considered in the first hour of care for an asthma patient was an assessment of severity with peak flow, as I've just highlighted, administration of systemic steroids within an hour, administration of beta agonists within an hour, as that obviously is what relieves patient's symptoms, and assessment of oxygenation and prescription of an oxygen target. Next slide. The way the urgent care stream are imagining that it will work is that all patients on arrival will have their News 2 score done. Those who are scoring 5 or more will need to be seen urgently by a member of the clinical team in the ED. And if that patient is judged to have asthma, that's when these standards will kick in, and it'll be measured regularly using data from the audit. So obviously we'll be needing to look at the way in which data is entered into the audit, and I'm happy to answer questions on that later if it's relevant. And there are also first hour of care pilots for a whole load of other conditions, mental health crises, overdose, stroke, etc., etc. Next slide. This is a breakdown on how we would be doing if the first hour of care metrics were already in place. And the data is slightly different from the data I showed you earlier, because first hour of care is only England only initiative. So these are the England only data. So in England, only 19% of patients had their peak flow taken within an hour of arrival in hospital. Only 37% received beta agonists within an hour of arrival, and 26% received their steroids within an hour. Next slide. And then in terms of oxygen prescribing, the key metric is this one on the bottom line, that 16.5% of patients were administered oxygen with no prescription. So oxygen, as you know, should be treated like a drug. And I can't imagine there's any other drug where anyone would be happy that 16% of patients who received the drug had no prescription recorded for it. So another challenge for us. Next slide. So I highlighted earlier on that one of the patient priorities for care was timely access to review by a respiratory specialist. And I should say that what's meant by a respiratory specialist in the audit is anyone with expertise in asthma care. So that could be a nurse, a physio, a registrar, a consultant, and it will vary very much from hospital to hospital. But it's also suggested in the NICE quality standards that review by someone with particular training is part of what good quality asthma care. Next slide. And actually, we found that in the audit that specialist review or review by a member of the specialist team drives high quality care. So first of all, if you're seen by a member of the specialist team versus a patient who's not been seen by a member of the specialist team, you are 25 times more likely to receive a respiratory care bundle, and you are, for instance, 8 times more likely to have your smoking cessation behaviours addressed. Next slide. This again is the run chart from my own hospital, and you can see that we've been working on respiratory review with that solid blue line above, and we weren't doing too badly before, but we have looked at the way in which the amazing nurses and physios I work with, and they now support an in-reach service into ED and MAU so that we pick up all patients admitted to the hospital as soon as possible in their admission, with the aim that we see every patient with asthma who comes into our hospital each year. And we have about 400 admissions with asthma a year. Next slide. We're actually across the UK doing an amazing job. So 81% of asthma patients are reviewed by a respiratory specialist during their admission. And then 68% get seen within 24 hours during the week, 56% at the weekend. Next slide. But overall, I feel to try and ensure that at least 90% of patients receive specialist review. And I saw a patient who was holidaying in Bristol recently who came from another area of the country, and this patient's had 2 intensive care admissions with their asthma and has never seen a member of the respiratory specialist team. They didn't even have a clear idea how to use their inhalers, and I know that we can do a lot better than that. Next slide. This is just a reminder of what the BTS asthma discharge bundle looks like. And it says that before discharge, patients should have their inhaler technique checked, maintenance medications reviewed, adherence discussed. They should have a personal asthma action plan either issued or reviewed, smoking behaviour looked at, and follow-up arranged. And 57% of all patients received an asthma care bundle, and those in receipt of a bundle, 37.5% received all 6 elements. And you were much, much more likely to receive the elements of best practice care, an odds ratio of 22 if you had a bundle versus if you didn't. Next slide. So 87% of patients, and I'm sure you'll agree those elements of the bundle, none of them are controversial, that, you know, if you come into hospital, you should have your meds looked at and try and plan for what happens when you deteriorate again. 87% of patients got 1 bundle element at least, 12% had none. And again, that's something that I think we can reflect on. The things that were done least commonly were organising follow-up and the personal asthma action plan. And there was a recent excellent review in the BMJ that showed that patients need at least 2 hours of education associated with their personal asthma action plan if you're actually going to see a change in care outcomes. So I think that's something that is going to be a challenge, especially as we move to minimising contact with patients through home care and things. Next slide. And this again is my own work in my local hospital on care bundles in the solid line and the national picture with the dotted line. So we're seeing improvements in both. Next slide. And then finally, I couldn't possibly talk about asthma care without talking about smoking. Actually, only 22% of patients who are admitted with asthma are current smokers, but 68% had their tobacco dependency addressed. So clearly we haven't won the battle there either, and that's an area that we need to continue emphasising in everything we do. Next slide. Next slide. So I get a bit depressed when I look at this slide. So this is the national picture of patients who smoke in blue, patients who have their smoking behaviours addressed in red. I haven't put the solid line on there because I'm too embarrassed about the performance of my own hospital, though I should have put that in, but my nurses got cross with me when I showed them this presentation because they're working very hard. You know, smoking is so important, but I have hope. Next slide. So this is the amazing graph from the COPD program, and the dotted line that shows that rapid gradient in 2018 for the number of smokers who've had their smoking behaviour addressed. We looked at this data and thought, what on earth has happened there? Because we hadn't changed anything about the way in which we entered the data, and we drilled down into the data to see what had led to that significant uplift in proportion of patients receiving interventions for their smoking. Next slide. And we found actually that entire shift in data nationally was because of work going on in the Northwest through the Smoke Free Manchester project and the Cure project, which focuses on training staff in hospital to be confident in smoking cessation. And my battery's about to run out. There we go. So if you haven't looked, I recommend you look at thecureproject.co.uk. It's really inspiring. And that previous slide shows that you can really make a difference. Next slide. And then the final thing that but which unfortunately was suspended during COVID, was that for hospitals who are paid per patient and for hospitals with block contracts, you can still look at best practice tariffs and build them into the contracts. We worked with NHS Finance to incentivize aspects of care that we thought needed to be improved. And the metrics that were included in the best practice tariff were provision of respiratory review within 24 hours, and then 4 elements of good practice: inhaler technique being checked, maintenance medications reviewed, personal asthma action plan, and tobacco dependency addressed. Next slide. And for those of you who don't know, a best practice tariff means that if your hospital crosses a threshold, and in this case the threshold is that 50% of the patients within a hospital should have all of those things I've just specified, then you receive a higher tariff for all of your asthma care. And in terms of the value, in my own hospital we earn just short of £200,000 a year for the COPD best practice tariff, which we can reinvest in the respiratory team, and we modelled that we would generate about an additional 80,000 in tariff from the asthma audit. But you can see that only 28% of patients received those aspects of best practice incentivised by the best practice tariff, and across the UK only 10 hospitals would have been eligible for the tariff prior to quality improvement work taking place. Next slide. And then one thing that I really want to emphasize is the importance of follow-up. So NRAD showed that if patients are having more than 2 courses of steroids each year, then they are at increased risk of death. We've recently done a review of EMIS records in my STP area, and over 1,000 patients who were on the QOF register for asthma had more than 2 courses of steroids in my patch. And nationally, when these patients are admitted and discharged from hospital, 10% manage to escape without any arrangements being made for their follow-up. And that's really key if we're going to reduce a small number of deaths, but also reduce the damage caused by regular steroids to patients. Next slide. So that brings me just to something I want to flag with you. It's another piece of work I've been doing with severe asthma centres across the UK. So we looked at data we had available to us through BlueTech, which is the system we prescribe asthma biologics on, and in the asthma registry, and we identified big variations in practice across the UK in a number of areas. And I've worked with over 100 people across the UK to produce a severe asthma toolkit, which is complete now, and again is going through the approval process, and which should hopefully be available later in the year. Next slide. The toolkit's available as an online interactive tool, and it will be eventually downloadable from the Respiratory Futures website. And it basically looks at 4 areas which are in the bar at the bottom here, where we saw huge variation in practice. So one area of variation is how patients are assessed for medication adherence and what interventions are used to assist people who are not adherent in being able to take their asthma medications more regularly in an attempt to improve their asthma care. We provided advice on how to structure an MDT and an asthma network. We saw huge variation in practice in choice of biologics, so we've done some work on that. And we also have worked with patients and commissioners at looking at how we measure quality of care from asthma networks as a whole. Next slide. I'm just going to flick through the next slides just to show you the look of the audit. So each of these areas on this slide, you can click through them to look at how you assess medication adherence, but more importantly, how you can respond to help patients improve their adherence. Next slide. This is the flowchart for choosing asthma biologics, and it's supported by leaflets that support patients in participating in the decision about which biologic is most appropriate for them. And those leaflets were developed very much by and with patients. Next slide. But the key thing for me was I was very frustrated by the way in which we measured whether asthma networks in the UK are effective or not. The way in which they measured seemed dry and not clinically relevant. We went through a Delphi exercise, which is a process of forming a consensus with a wide range of clinicians. Over 60 clinicians responded. We worked with Asthma UK to get patients to respond. We had over 100 patients, and we also had commissioners. And we gradually drilled down to 5 metrics which we thought would provide clinically meaningful outcomes to measure the success of asthma service. So these were number of exacerbations leading to A&E attendances, exacerbations in a year requiring oral corticosteroids, patients' baseline oral corticosteroid use, and then improvements in ACQ6 and mini AQLQ scores. Next slide. And then the other area that we're going to be working on with severe asthma is working with a group called the Accelerating Access Collaborative, which is an industry AHSN NHS collaborative, which looks at improving access to medications. They're going to be looking at asthma biologics in the next year and identifying system blocks that lead to patients not being assessed when it is deteriorating for biologic treatment. So Joe mentioned that. I just wanted, just at the end of my talk, just to mention a little bit about the wisdom that we've derived so far about the challenges of bundles. And the first thing I'd like to look at is the BTS pilot for COPD bundles. And I've noticed that some of the hospitals dialing in now, I recognise participated in the audit, and I'm not going to remind you what bundles are because I know that you're experts. But as you know, the COPD discharge bundle requires inhaler technique and medication review, self-management plans, smoking status, suitability for PR, and follow-up, all to be arranged before discharge. Next slide. And this is, next slide. This is the overall results table. And if you just look to the right here, you can see how process reliability was improved by using a discharge bundle. So for instance, in the BTS pilot, which included 2,200 people in the discharge bundle arm, you could see that the number who had their meds reviewed increased from 20% to 74%. Those whose smoking was addressed went from 66 to 90%, and follow-up arrangements went from 32 to 76%. So there was a big improvement in reliability of care. Unfortunately, in my slide deck, I'd highlighted some of the key things about the admission bundle, but in fact, what we found was that the admission bundle was much harder to implement, and we saw no improvements in care, but that's because bundles were unreliably implemented, so they didn't actually improve the reliability of care. Next slide. Oh, I did. And next slide. But what we did find was that when we looked at individual patient data, elements of the admission bundle seemed to make a big difference. So for instance, if you had your oxygen assessed, your need for oxygen assessed and prescribed, you were actually 80% less likely to die. And bear in mind, this was a sample of over 2,000 people. And if you received timely treatment, you were 40% less likely to die. Interestingly, administration of NIV early wasn't associated with a reduction in mortality, but it was associated with a significant reduction in length of stay. Sort of confirming the importance of good quality care in COPD in this case. Next slide. But these results were tantalizingly interesting enough that NIHR funded a randomized trial of COPD care bundles, and I believe that you discussed it at a previous collaborative meeting. And essentially, we had 19 sites who told us that they were implementing bundles, and 12 comparator sites who told us they weren't implementing bundles. And overall, we had data from the NHS on 19,000 admissions, but we had patient level data from 7 implementation sites who were matched to 7 comparator sites, where we had a significant amount of patient detail. And we also conducted qualitative research at 6 sites. Next slide. And the results were very interesting. So first of all, being in an implementation site for care bundles improved process reliability. Next slide. But what we found is that the reliability of care did not increase to any extent, to the extent it did in the BTS pilot. So for instance, if we look at medication review, those in comparator sites who said they weren't introducing bundles showed that only 16% of patients had medications reviewed. In the implementation sites, it was 13%, but in the overall BTS pilot, that was closer to 80%. Next slide. And next slide. So if you click through these red boxes, we'll scroll down. So actually, I wasn't wanting you to do that, but never mind. If we look at receipt of a personal action plan, a bundle increased that from 20% to 45%. But again, in the BTS audit, it was increased to a much greater extent. So 2 things came out of the audit. So first of all, being in an implementation site, after discharge, you were much less likely to be readmitted. So there was a 40% reduction in the risk of an A&E attendance, but all of the other outcomes in the study around reducing 28-day readmissions, all-cause readmissions, in-hospital mortality, length of stay, total bed days, etc., were not statistically significantly better, but for every single metric, there was a non-statistically significant improvement. But when we actually looked, hospitals who were in implementation sites did not implement bundles as reliably as had been done in the BTS pilot. And in fact, one site that said that they were an implementation site, only 2% of patients received a care bundle, and the average was actually less than 50%. And then in some of the hospitals who said they weren't implementing bundles, they actually sneaked checklists in during the study that looked remarkably like bundles, albeit they weren't introduced with a quality improvement methodology. Next slide. Next slide. Next slide. So this led me to reflect that 3 things are required to achieve improved outcomes in care through use of care bundles. So first of all, the targeted outcomes in the care bundle must be sensitive to change and responsive to elements within the bundle. Next slide. And I think we can see from the BTS pilot and from the NIHR study that bundles improve reliability, and that when bundles are fully implemented, you do see improvements in care. And we saw that at a level of statistical significance with the BTS pilot, and we saw improvement in ED reattendances for the NIHR study, and a trend towards improvement, albeit with the caveat about bundles not being introduced as reliably and as widely as I would have liked for the NIHR study. Next slide. And next slide. But it was clear from the NIHR study that the real challenge, which you're all aware of in the KSS collaborative, is that it's not enough to have a tool like a bundle, and the real key thing is actually implementing it. And we didn't implement it reliably in the NIHR study. Next slide. We looked at some of the sort of structural things that contributed, in the opinion of clinicians, to bundles being implemented. We did 43 in-depth reviews, and that was both hospital care, primary care, but we also interviewed patients and we observed care within hospitals. And the things that were emphasised as being important were the presence of an identifiable clinical leader, and we saw examples of different hospitals of those clinical leaders being nurses, physios, doctors, and in one hospital actually a patient who was working closely with the department. And also we did find that financial incentives made a difference because they helped clinician and managerial objectives to be closely aligned. And next slide. So the barriers were, or the pitfalls, are really to ensure you have clinical leadership and organisational buy-in before you start on quality improvement projects. You need to understand the whole pathway. It's tough collecting data, especially at the beginning, but the aim is not is better patient care, not better data. But you do need that data so that you know you're doing the right thing. Next slide. And then I think this will be my last slide. So just to remind you that Deming, the sort of father of quality improvement, highlighted that discharge bundles, or highlighted that quality improvement needs to be part of system change, and bundles are only one component of a wider system, and their true value comes when the system changes to facilitate the implementation of the bundles. And I'll stop there so I don't go over time. Thank you.
Thank you, James. That was great. That was really compelling, really, to do some quality improvement work around asthma, and I think gives us some sort of more granular thoughts about COPD discharge bundles. That actually say it's the quality of care, not the tick box on the audit, but they need to link up. So thanks very much. So we've got time for a few questions. Julie, if I could ask you to facilitate those, please.
Right, thanks very much, James. As always, a brilliant overview. And Andrea Barnes, who's a respiratory nurse in St Richard's Hospital in Chichester, wants to know how you improve the A&E practice in getting peak flow readings within an hour.
Yeah, so particularly during COVID, that's obviously going to be a challenge because it's seen as an AGP. The way we've dealt with it in my hospital is we have rapid front door testing, and we cohort patients into COVID and non-COVID areas. And if you're COVID negative in a non-COVID area, then we have wide access to side rooms so we can do peak flow. But I accept that probably during COVID, it's going to be a struggle to get peak flow done within an hour, but really what we need to get away from is the 21% of patients who never have their peak flow measured, and because that's clearly not right, that we're not seeing that objective assessment of severity. Now, there are other ways of objectively assessing severity by looking at respiratory rate and the number of words in the patient's sentence. It's all set out in the guidelines how you do that. But yes, it will be a challenge in COVID, but that shouldn't mean that we don't try and do better than we're doing at the moment.
Thanks, James. And the Saskia Edwards who's a physio from Sussex Community, wants to know if you've got data on the number of secondary care settings able to offer multidisciplinary asthma services. As she says, we need to improve patient access to specialist nurses and physios in secondary care. We appear to have lost James briefly. Can anyone get James back?
He's back.
Hey.
Sorry, I don't know what happened there.
Well, there was a subliminal door opening behind you. It's probably a ghost coming and turning people off.
Yes. So access to multidisciplinary teams, is that for severe asthma, is it?
She doesn't say. Saskia, did you want to qualify that question if you unmute yourself?
I think just anybody who's accessing a secondary care consultant, that would be part of the assessment process.
Yeah. So there are two things that should facilitate better access to that multidisciplinary assessment. So one of them are the respiratory networks, which Andrew Menzies-Gow highlighted there. They're going to be receiving about £500,000 worth of funding a year, and they are going to be held to account for improving integrated care and multidisciplinary care of long-term conditions like asthma, like COPD, has to be front and centre of the way we work in respiratory medicine. We've done quite a lot of work behind the scenes over the last year. So every area of the country now has a severe asthma network. Some of those severe asthma networks are very new, but the responsibility of the hubs in those networks is to ensure quality of care, both within the hub, but also within all hospitals who are contributing patients to the network. And there's exciting work being done to look at how we identify patients who are overusing inhaled steroids, inhaled short-acting beta agonists, and overusing oral steroids in the community, and actively engaging case finding. So as part of work stimulated by the network in my own area, the paid for prescribing scheme for community pharmacists is to identify and intervene in those 1,000 patients I mentioned who are using more than 2 courses of steroids a year, because that for me is an asthma champion is an embarrassment. I'm not supporting my colleagues in primary care to identify and manage these patients, and that the responsibility for that sits with me within the system, because GPs and practices are overloaded looking at a huge range of conditions, and what we need is that exchange of information and understanding between different areas of the whole system that should be caring for our patients.
Mm-hmm. Thanks, James. And we've got a question on the finances. So Emma Davies from Sussex wants to know if the financial incentives that you mentioned are best practice tariff and QOF, or whether there are any others.
Yeah, so there is there's a sequin for severe asthma centres, but that will be less relevant to the majority of people on the call. But no, there's a best for COPD, a best practice tariff for asthma. We were talking about best practice tariffs for pulmonary rehab, but when COVID came in, the NHS suspended all financial incentive schemes, and that's what I was asking Andy about in my question earlier on. There is talk that they are going to be looking at how you can incentivize the NHS generally to focus on delivering good care rather than providing a base tariff for care, whatever the quality. At the moment, we don't really link up incentives and outcomes very well in the NHS, but I've been participating in an exercise at looking at how we could do that in a more smart way, perhaps a little bit in the way in which QOF has driven really great improvements to care in things like diabetes, but less so in respiratory, because I think the QOF markers originally in respiratory were the wrong markers. They were more process measures rather than important patient outcome measures.
And thanks, James. We've got a couple from primary care here. So Stephen Litton in Seaside Practice wants to know about given the delay in emergency department's response to acute asthma presentation, do you feel primary care should have a greater role? And then Sarah Pearce at Royal Surrey Hospital is asking how you overcome the logistics of arranging primary care follow-up post-admission. So it's about the role of primary care and follow-up in primary care.
Yeah. So the way in which patients are followed up after hospital discharge, I'll answer the second question first. We deliberately left fairly woolly because we recognise that will vary hugely from area to area. So at the moment, a large part of our CCG is in crisis in terms of primary care. We've got practices closing left, right and centre, practices combining, large numbers of vacancies. So at the moment, the way in which we follow patients up is our specialist nurses ring patients 4 days after discharge to see how they're getting on, but we recognise that this isn't sustainable. So we're working with our local community partner who delivers community services for them to operate an in-reach service into the 3 emergency departments in my healthcare system, and then provide patient education at the point when people are in hospital, and then at 1 week and 1 month after discharge. Also, I think retail pharmacists and community pharmacists are the biggest untapped resource of expert professionals in the community, and one of my passions going back over a very long time is looking to see how we can bring them on board and make the most of their significant skills, and there are already good models of practice pharmacies where you can be supported, but we are looking to see how we can work with local pharmacies so that they can do focused respiratory reviews to some of those elements of good quality care that I've highlighted during my talk.
Excellent. Yes, of course, absolutely key colleagues. We're just going to take one more question. I think Joe wants to wrap up. So this is from Joy Lindsay in East Sussex, asking how they can check, or are they safe to use in-check dial to measure patients' inspiratory effort during the current time, so while they review as part of the COPD or asthma discharge bundle?
Yeah, so that's a very complicated question. I'm going to try and give a simple answer. So just so you know, my research colleagues in my hospital have been given $500,000 by the Department of Health and are walking around with really annoying machines that measure droplets, looking at what really are AGPs and how significant is the risk. And in fact, the viral filters that we put onto the machines we use are pretty much 100% effective. So if a patient blows through a viral filter into a machine, there are no droplets. The droplets arise if the patient then coughs when they take it out their mouth. So that is our challenge. So pretty much, as long as you're using, obviously you can't use a filter in an in-check device, but filters are effective. I'm not a big fan of in-check devices. I think they're trying to introduce science into an area where actually the science isn't good. And I much more trust my judgment in looking to see how much oomph people have and use my clinical judgment. And actually, I prefer to watch people using their inhalers. And I don't just think, can they use their inhaler when they're well? I think, can they use their inhaler when they're sick? So if I think it's marginal when they're well, I tend to go for MDIs or soft mist devices rather than dry powder devices.
Thank you. I think that's Joe's going to wrestle control back now.
Yeah, so thanks. I'm so glad to hear you say that, James, because I feel exactly the same about watching people use inhalers, but I sometimes feel that I'm, the odd person out. And when you said MDI, I'm sure you meant with a spacer.
Of course, always. Is there any other way of using them?
Absolutely not. Okay, so that was great. Thanks so much, and thanks for people's questions that were really interactive. So we've got like 6 minutes now to do what you need to do, and then we will be back to hear from Mark Clipman. So thanks again, James. Thanks, everyone.
Thanks so much, Joe.